CALGB 40603 was a randomized phase 2 study designed to determine whether the addition of either carboplatin or bevacizumab would increase pathologic complete response rates in patients with stage 2 or 3 triple-negative breast cancer. The correlative studies that I'm going to discuss today were performed on samples taken from each patient prior to the start of treatment. As presented at last year's meeting and published in the Journal of Clinical Oncology subsequently, the study showed that the addition of either carboplatin or bevacizumab to standard neoadjuvant chemotherapy significantly increased the pathologic complete response rates seen in this subgroup of patients. The correlative studies are really designed to see if we can identify clinically relevant subgroups of patients who receive either greater or less benefit from the addition of these agents. I think the appropriate analogy could be to the role of HER2 and Herceptin, whereas we know that the addition of Herceptin has little or no benefit in HER2-negative patients, but a much larger benefit in HER2-positive patients. One subgroup that we were particularly interested in looking at were the basal-like patients as defined by gene expression array. Based on retrospective analyses, we expected this to account for about 70 to 80% of our triple-negative breast cancer patients. And the question is, would carboplatin or bevacizumab increase pathologic complete response rates in this subgroup? And would there be an interaction between subtype and pathologic complete response benefit? We also looked at select mRNA gene expression signatures to see whether they would affect the pathologic complete response rates and the impact of the addition of carboplatin or bevacizumab on pathologic complete response. This was done by doing RNA sequencing on a total of 360 pretreatment tumor samples and comparing those results with results in samples in the Cancer Genome Atlas to define PAM50 subtypes, including basal-like and Claudin-low subtype, and also to look at these particular mRNA gene expression signatures. And then statistical analysis was done to see what effect these had on pathologic complete response rates and on the benefit of adding carboplatin or bevacizumab. These are the initial results of the subtyping from our study. If you look at the pie chart on the left, you'll see that 87%, so a higher percentage than we had anticipated, proved to be basal-like in our analysis, with much smaller percentages of patients having other subtypes of cancers that I will collectively refer to as non-basal-like. You can see that the distribution of subtypes across the 4 treatment arms was the same, and the overall pathologic complete response rate in the breast was similar between patients with basal-like cancers with a 54% PCR rate and non-basal-like cancers with a 52% PCR rate. These are results with the addition of carboplatin in the basal-like subtype. You can see that the addition of carboplatin increased pathologic complete response in the breast from 47% to 61%, and pathologic complete response in the breast and axilla from 43% to 56%, and both of these results were highly statistically significant. But the interesting thing is that for carboplatin, the benefit of its addition on pathologic complete response rate was equivalent in the basal-like and the non-basal-like types. And because of this, there was no significant interaction between subtype and the benefit of adding carboplatin. Now, I want to emphasize that this doesn't mean that carboplatin was of no benefit in the basal-like subtype. We saw from the previous slide that it is. There was simply no accentuation of that benefit in the basal-like subtype compared to non-basal-like cancers. That is, we did not identify a subtype of triple-negative breast cancer that did not benefit from the addition of carboplatin. For bevacizumab, in basal-like patients, the addition of bevacizumab to standard neoadjuvant chemotherapy increased the pathologic complete response rate in the breast from 45 to 64%, and in the breast and axilla from 43 to 57%. Again, both of these results were highly statistically significant. But in contrast to the carboplatin results, in patients with non-basal-like tumors, the addition of bevacizumab actually reduced the pathologic complete response rate, and thus, for bevacizumab, there was a statistically significant interaction between subtype and PCR benefit. Now turning to mRNA gene expression signatures. We looked at 5 different immune signatures which reflect both the extent and the character of tumor-infiltrating lymphocytes. And all 5 signatures analyzed, higher levels of expression of the immune signatures correlated with higher pathologic complete response rates in all patients and in patients with basal-like cancers. And these results are similar to those that were presented earlier this year from the Gephardt-Sixto study by Denkart and colleagues. However, there was no association between these signatures and a greater PCR benefit with the addition of carboplatin or bevacizumab, with all p-values for interaction greater than 0.2. And this is in contrast to results from Gephardt-Sixto, which reported an interaction between immune signatures and a greater benefit with the addition of carboplatin. Looking at other gene expression signatures that we analyzed, we found that high proliferation signature was predictive of pathologic complete response rate in all patients and of greater benefit with bevacizumab. Low estrogen signature was predictive of pathologic complete response and of greater bevacizumab benefit in all patients and in the basal-like subtype. And a high TP53 mutation signature was predictive of a higher pathologic complete response rate overall and was strongly predictive at a p0017 of bevacizumab benefit. On the other hand, none of these signatures was predictive of greater PCR benefit for carboplatin in either all patients or in the basal-like subtype. So in summary, PCR breast rates did not differ between basal-like and non-basal-like cancers. The addition of either carboplatin or bevacizumab was associated with significantly higher PCR breast and PCR breast and axilla rates in patients with basal-like cancers. There was an interaction between subtype, that is basal-like versus non-basal-like, and the size of the PCR increment only for bevacizumab. Expression of immune signatures was associated with higher PCR rates, and expression of high proliferation, low estrogen expression, or high TP53 mutation signatures was predictive of higher PCR rates overall and of greater PCR benefit from the addition of bevacizumab.
Thank you very much. Can you comment as to whether providers should now use carboplatin neoadjuvantly in all patients with triple-negative breast cancer?
Thank you. I would say that the jury is still out on the role of carboplatin in the neoadjuvant setting for triple-negative breast cancer. And I think it depends on your interpretation of results presented over the last year and a half from our trial and from Gephardt-Sixto. On the one hand, if a clinician says there was a 14% overall increase, absolute increase in the pathologic complete response rate with the addition of carboplatin in these two studies, therefore I'm convinced that carboplatin is a beneficial drug in these patients, that it's available, though not approved for this indication. It's inexpensive. It is associated with some increased hematologic toxicities, but otherwise no significant toxicities. And we think that because of this, it's worthwhile to do. Another person might say, another clinician might say, well, yes, there is this increase, but maybe it isn't as high an increase as we'd like to see. And we don't have long-term outcomes, that is relapse-free or overall survival yet. And there is some increase in toxicity with this drug, and therefore I'm not going to. So I don't think that the results presented today would really change anyone's mind. I mean, what we haven't done is identified a subgroup in whom the benefit is much greater, but on the other hand, we also haven't identified a subgroup who doesn't benefit from the addition of carboplatin.
Thank you.
Questions from the room then?
Dr. von Minkwitz, I believe you are an investigator on these others, the Gephardt-Sixto. Can you comment on these findings compared to what you've found?
Well, I couldn't have said it better than Bill. The summary of the interpretation of the two studies. So they both go in the same direction. They both have they don't have mature survival data available, so the full assessment is not possible. But it's a risk-benefit assessment that has to be done together with the patient. And of course, there are other aspects like the breast tumor size relation, in how far really maximum response is required or of benefit to these patients.
So it's not yet standard of care in Germany?
Well, if you ask, we did a survey in our group, and it's used, and in my group, so in the group of investigators, it's used by all of them. And the guidelines, in Germany, they say you are allowed to use it. You don't have to use it, but you're allowed to use it. So many of colleagues are doing it.